Hello and welcome to Arbor Rehabilitation's brief webinar on the OASIS and Section GG. My name is Cindy Hudson and I'm the Director of Clinical Compliance. I support education and compliance with Arbor Rehab, and I appreciate your time and attention for this brief session today. So I want to touch base a little bit about our agenda for our webinar, and our objectives are going to be for the participants to understand when Section GG scoring is going to be required, to know the specific items that are being scored in Section GG, and know the importance of accurate Section GG scoring at this point in time. Starting with a note of caution that to be aware, Section GG is not the same as the M1800 series of questions on the OASIS. The actual questions themselves are different, the items are different, the assessment is different, how we look at things will be different from M1800 series to Section GG. The coding scales are different. So we need to be bilingual in a sense and be sure that we're clear on when we're looking at those 1800 questions versus Section GG questions, that we know which criteria to apply to which assessment with that individual. Okay, and to be aware that CMS does understand that there's going to be differences between those M1800 responses to Section GG information. So they know that they're similar, not the same. You're going to get different scoring, different criteria with those. So fortunately, CMS does recognize that they have set us up to be a little bit inconsistent, I suppose. It would appear that we're being inconsistent in our documentation. So the what and the why of Section GG, it started with the IMPACT Act of 2014. It will standardize some language regarding the function across all of our post-acute care providing environments, from home care, SNFs, inpatient rehab facilities, and it will enable CMS to make a comparison across all those post-acute care providers, looking at length of stay, patient outcomes, the cost. They're looking at where they're going to get the best bang for their buck, depending on the type of individual that's being admitted. So we want to be sure that our outcome information, our Section GG reporting, is as accurate as it can be. And for those of you that have worked in a skilled nursing facility since about 2016, you know that we do have Section GG information gathered there as well. Okay, so it became mandatory for all home health agencies in January of 2019. It's not new for the home health agencies. However, there's been an increased focus on the accuracy of what we're reporting. If we don't accurately give information about Section GG scores to our agencies, it can result in obviously inaccurate outcomes, and that can result in some reduced payment to our agencies as well. The Home Health Compare website is going to show an agency's success rate in areas such as walking, medication management, bed mobility, pain, bathing, all those kinds of areas of rehospitalization rates. We can impact those scores with good Section GG reporting. So what gets uploaded onto that Home Health Compare site, we want to look as good as we honestly and accurately can report. So again, this will have an impact then potentially on what kind of managed care contracts the agency can work with. Our consumers are getting more savvy. They know where to go to look for information. They know where to go to look for any kind of feedback or ratings of different agencies. And this Home Health Compare site was meant to do just that. So we want our agencies to look as best as possible when the individuals that we're serving or their children who are now 40, 56 years old are surfing the net looking for information. We want good information to show up about our agencies. So again, with what it is with Section GG, and many of you have been doing this for a while, but we want to reiterate the importance of accuracy and make sure we talk about some of the criteria. So the Section GG score is independence related to ADL and mobility areas. It's based on a 6-point scale, as well as there's 4 additional characters that are going to indicate why a particular item might not have been scored. And those areas have to have precise definitions followed so that we're scoring accurately and consistently between all the agencies, clinician to clinician, even with yourself. Okay, when you go back and you do a discharge score, you want to be consistent. So this is a brief snapshot of what the OASIS looks like for the ADL areas. I realize it's kind of small, but you do see it in the EMR, the electronic medical record systems that you work with. The information is going to be required upon start of care or resumption of care, which is shown in yellow to the left. And then upon discharge, if the discharge goal gets documented, we don't have to do a discharge goal for all areas, but typically 1 area for ADLs and 1 for mobility areas will suffice, depending on your agency's criteria though. And I want to make a special note of some things, that things we might take for granted. We know what eating is, but by definition, what Section GG is looking for example, is the ability to use suitable utensils to bring the food or liquid to the mouth and swallow that food or liquid. once the meal is set up for the individual. So again, if you were assuming it included setup, if you didn't think it included swallowing, that might be a little bit of an update for you. So you want to be sure you're really clear on these descriptors and what it is that they're actually asking for with Section GG scoring and the items. The other point to make is that with the scoring, to be accurate, we do have this GG Crosswalk tip sheet. It's available for our therapists on the Arbor Rehab website. If you click under the employee portal, as you get into the employee portal, you register to use it. Once you're in, on the left-hand side, down the left-hand column, there's a whole space dedicated for home health resources. And this is housed there. You can print it off. I strongly recommend you do, and almost memorize it so that you've got this information readily available when you're looking at scoring an individual. We know we have our therapy coding from Min, Mod, Max Assist, Contact Guard, whatever it might be, and that gets lumped in a little bit differently for Section GG. For example, they look at somebody who is able to do half of the task or less than half of the task without assistance, and that then might make them either substantial or max assist or partial moderate assistance. We don't really look at it in that terminology, but we need to be able to do that translation so that we get accurate GG information on the OASIS. Okay, so again, make a point of printing it and memorizing it if you can, or at least have it readily available when you're scoring GG items. So with eating, and again, we're going to talk a few things about some special conditions to be aware of as we work through the descriptors on the OASIS. With eating, if the person has a G-tube or uses TPN for nutritional intake, the assistance with those tube feedings and TPN is not considered a part of the GG scoring, okay? If they don't eat or drink at all by mouth due to a recent onset, then we're going to not look at eating for medical reasons. New TPN or new G-tube, and we're not looking at eating for medical reasons, then we would code it as an 88. If they've been on a tube for a long time, they haven't eaten anything by mouth for a long time, then maybe that would be, for example, a 9 and not applicable. Okay, so we want to be careful with how we're scoring. In addition, when we're looking at eating and oral hygiene, if they eat and drink by mouth and they only get some of their calories on some of their hydration through a tube, then we do want to code based on how they're doing with the part that they do eat. If they don't do oral hygiene during your evaluation, which is probably the case, you can determine their abilities based on their performance of either similar activities during the assessment or based on caregiver report, the patient's report. But you might want to ask them, hey, tell me what you do to brush your teeth and take care of your mouth, and see what they say, see if they can demonstrate, some of the motions they might need to make and or take the caregiver's report for how they do with that. With toileting, hygiene, and showering, again, toileting hygiene does not include the actual transfer, so we want to be careful that we're only coding based on toileting hygiene. And regardless of where they void, it is looking at that hygiene. So if it's a bedpan, a bedside commode, or over it with using a toilet frame over the toilet, again, it's still looking at those hygiene areas. Showering does not include washing the back or washing the hair. It does not include the transfer. It's just really looking at washing and drying the body. It doesn't include a daily, partial sponge bath, but it may include a full sponge bath if that's what the person's doing. With toileting, if the person has the Foley catheter in place, the urinary catheter in place, then we're not going to be able to code for that hygiene, but we can code for the hygiene after a bowel movement. Again, that might be based on the patient or caregiver's report. With upper body dressing, lower body dressing, and footwear, it includes dressing and undressing. It includes the fasteners. It includes any kind of braces or supports they might be wearing. When you're looking at dressing, it does not include the footwear. That's going to be its own separate category. And upper dressing does not include hospital gowns. If they've got a prosthetic limb, you want to code donning and doffing of the stump sock, the shrinker, the limb itself. That all goes under lower body dressing. With footwear, excuse me, if the person wears an AFO, that would be considered a part of their footwear, along with any kind of orthopedic boots, support hose, those kinds of things. Socks, shoes would be considered footwear. Again, this is a really, I know, a pretty crowded looking screenshot here. This is the mobility areas that may be looked at on the OASIS for Section GG. Certain areas are going to be skipped if they're not applicable. We're going to touch base on this here as we go along. So it's looking specifically at bed mobility, and it breaks it down into rolling from left to right, which includes lying on the back and then rolling left and right and returning and lying on the back. It looks at sitting to lying, which is moving from sitting at the edge of the bed to lying on their back. And it also looks at lying to sitting at the edge of the bed. So it's going to be looking at the person's ability to go from lying on their back to sitting at the edge of the bed with their feet flat on the floor and no back support. So again, if they need, if their trunk control is poor, and once they're sitting at the edge of the bed, you need to steady them and support them, you're going to code lying to sitting at the edge of the bed based on how much support they need to sit safely at the edge of the bed. Again, looking at the feet being flat on the floor. So if you need to put something in place or adjust a hospital bed height so their feet are on the floor, then that's going to affect your scoring as well. Looking at more bed mobility tips, at the time of the assessment, the person's unable to lie flat due to medical conditions or restrictions, but they were doing it before this episode of illness, you would probably code that as an 88 because it wouldn't be medically safe to have their bed be flat, for example, if they have a PIG tube. But if they've been sleeping in a recliner for a long time, for example, and you're not looking at it for that reason, then it may be a 9 for not applicable. What also CMS says, and I realize this feels like a little bit of a contradiction, they say that your clinical judgment can be used to determine what is considered a lying position for that individual. So for example, if because of comfort or whatever, they like to have a bunch of pillows, you know, and they're really more up like 20 degrees, not really lying flat on their back, but that's the way they roll, then that's how we're going to look at it for that individual. We could consider that them lying on their back, okay? Sitting to standing, chair to bed transfers, toilet transfers. So sit to stand does not include any of those bed mobility areas. It's separated out. So be sure when you're scoring, you're not including how they did with bed mobility when you're looking at purely sit to stand skills. If a mechanical lift is used, it's typically going to be coded as dependent, even if the person is helping with that actual transfer. And again, a toilet transfer, if a cue is needed to use any of the equipment, whether it's a armrest on a bedside commode or a grab bar by the toilet, or to use the walker to get to that toilet safely, if you need to cue them to use any of those devices, even if that's all you do is cue them, then you're probably going to score them as at least a 4, a supervision. So an important thing to note here is that anytime you cue a person to use any kind of device, whether it's a reacher, walker, grab bar, then they're not independent, and you need to score them at least as a 4 that they need supervision, because using that equipment for their safety was a part of doing that task, and they needed at least that cue, they needed the supervision to do that, okay? Hopefully that makes sense, and that's going to be true regardless of what area you're looking at with section GG. With car transfers, it includes the transfer in and out of the passenger side of the car or a van, but it does not include maneuvering the safety belt or the door itself. Oftentimes, obviously, on the eval, it might be scored as an 88 because medically it's not a good thing to do with that individual. Kind of why they're homebound, is getting out and about doing that car transfer can be a difficult challenge for them. So again, you might be coding it as 88 and just justify why. You know, if upon discharge you could look at it, but it's a blizzard outside or it's 95 degrees and it's not safe for that person to go out in those conditions, then you might code it as a 10 because it's not environmentally feasible. When we're looking at walking under section GG, it's looking at the ability, once the person's standing, again, sit to stand is different. Once they're standing, can they walk 10 feet on a level surface? The next area is looking at, can they go 50 feet with 2 turns, which is in either direction? And then the turns should not jeopardize the person's safety. Again, that might affect your scoring if they needed support for those turns. Again, you code if they need a cue to use any of those devices that they should be for safety, cane, walker, whatever it might be. A little bit more about walking. They're going to also look at walking 150 feet on an even surface as part of the section GG scoring. And if the person's environment doesn't accommodate a walk of 150 feet without turns, you can score them based on doing, for example, 3 consecutive 50 feet stints or 50 feet walking distances to total 150 feet. All right, so hopefully that makes sense. Again, that's going to at least enable people who live maybe in a smaller apartment or a trailer to be able to demonstrate the ability to go 150 feet if they have that potential. More on walking. Walking 10 feet on an uneven or a sloping surface is another area that GG is going to look at. And if they can't attempt walking on an uneven surface because of the weather or because there's no uneven surfaces available, you might score them as a 10 because there's environmental limitations. And certainly initially you may not want them out on that uneven surface or on a slope. So that might be 88 initially because it's not medically a good idea. It's not medically safe for them to do that. With steps, GG is going to look at their ability to go up and down at least 1 step or curb. And depending how you answer that, if they can't even do 1 step or curb, most EMRs are going to eliminate looking at 4 steps and looking at 12 steps, okay? If 1 step is difficult for that individual, you might code it as 88. They might refuse it, which would be a 7. Maybe there is no steps. It would be appropriate to code it as not applicable, a 9. So again, if you need to look at those areas, make sure you know those not tested codes, and then you might be skipping looking at those steps. Okay, if they can do 4 steps 3 times in a row, just like being able to walk 50 feet 3 times in a row, you could code them for 12 steps. Okay. So picking up an object, the ability, CMS says it's the ability to bend or stoop to pick up a small item, such as a spoon. So again, that kind of gives you a parameter of just how small an item, I guess, might be that CMS is looking at. The ability to use, or do they need to use, a wheelchair or a scooter is another section that we need to answer. And if it's no, you can skip the additional wheelchair questions. So that's kind of a good thing. But if it's yes, if they do use a wheelchair for in-home mobility, then you need to look at their ability to maneuver the wheelchair 50 feet with 2 turns and maneuvering that chair 150 feet on an even surface. And again, some of those descriptors for the turns and 150 feet apply from walking as well as wheelchair. Like, for example, going 50 feet 3 times in a row. If the person, however, is pretty ambulatory and they're only using a wheelchair for community distances or to get down a long apartment hallway or assisted living hallway, if they're only using it as a transport, then we would answer that question, no, they do not use a wheelchair. We can answer 0, which then would enable you to skip those additional questions about wheelchair mobility. All right, but make sure that they really are not using that wheelchair for in-home type mobility. Also with wheelchair and scooter mobility, again, as I said, the same with ambulation questions. The turns are 90 degrees in either direction or the same direction. And again, we can look at consecutive mobility as well. The goals for Section GG, we need to at least have one goal written into the Section GG area. Your agency might dictate differently, but this is what CMS is requesting. They might have a little bit tighter restrictions for a better safety net, I guess. We need to choose maybe making a goal for an area that that person is likely to succeed with. So don't make it something like 12 steps they may never get to, but maybe it's walking 50 feet with 2 turns. Other goal areas can be dashed out according to CMS without any kind of penalty. Again, your agency might dictate differently. We only need goals at that start of care or resumption of care. And again, therapists can document a goal for an area that was initially not attempted. So if initially you don't look at uneven surfaces or car transfers, you're going to code them as an 88 because they just couldn't handle it. But you want to make a goal for that, that's perfectly fine. CMS doesn't take issue with that, fortunately. Talking about prior level, this is something else that Section GG is going to gather data about. And it's going to look at self-care, cognition, mobility, and stairs. The scoring criteria for prior level is different, of course, just to add another layer of complexity. There's 5 different areas, and so 3 is independent, whereas on the other scale, 6 is independent. 2 needs some help, and 3 is dependent. 8 is when a prior level of function is just absolutely not known, and 9 is not applicable. And you can see this is a slide from a CMS presentation, and again, they say a dash is a valid response, however, they expect it to be a rare occurrence. So we really don't want to dash out prior level either when we have information that we can gather, again, from the medical record, from the interview of the family, caregiver, however we can get information to fill in that prior level. Again, this is a screenshot from the actual OASIS, looking at what they're defining for self-care, indoor mobility, stairs, functional cognition, as well as looking at prior device use. So that's what this is going to look like on the OASIS, and it's got the descriptors there for you. Looking at prior device use, it's going to identify their use of devices or aids immediately prior to their current illness. So if they used a walker 5 years ago after hip surgery, now they weren't using it for the past 5 years, that would not count for their prior level, okay? It's only gathered at the start of care or during the resumption of care. So we're not doing that all the time, at least. Again, Section GG coding and timing. We do it at the start of care, resumption of care. We would do a discharge when they discharge from the agency, not to an inpatient facility. Again, we may be gathering some data. When we're looking at the discharge, again, that needs to be gathered, that information is gathered 5 days prior to their discharge from the agency. Some other coding tips, and again, usually the EMRs, the electronic records, are going to cue us when we need to do a Section GG OASIS. Some additional coding tips, you want to carefully read each item description and code exactly according to that definition. So you can see if, for example, you did not include swallowing as you're scoring eating, that could be inaccurate and skew the results. So you want to be really careful to know those descriptors, know the coding, because it's a different scale than what we're used to in therapy. The data is going to be gathered from your observations and for reports, but you don't want to assume skills. Don't extrapolate here, don't assume. Really use your observation and interview skills to get good information for individuals. If the assistance is required because the person's performance is unsafe, or of such a poor quality, again, you need to score according to the amount of assistance needed. So maybe somebody is really confused, although they're pretty mobile. And if it's hands-on assistance to get them to, not trip over things and that type of thing, that's how you're going to code it, even though you're not physically assisting them to walk, but they need a lot of supervision or hands-on assist to be safe. That might be where that would affect your scoring. And again, they're looking at scoring for usual performance. So it's not their best ability to do a task. It's not their worst ability to do a task. It's how they usually do a task. So again, that might be where you gather data from the caregivers or family members or the individual themselves, because by the time you're looking at them during your evaluation, it might be the afternoon and they say, well, I do good in the mornings, but afternoons are rough. Whatever. You can factor in that information when you're coming up with that GG scoring of their usual performance, okay? Think about the location, time of day, do they usually do this in the bedroom, but you're having them practice it in the living room? That kind of stuff can affect scoring as well. So think about how it would usually look for that person, and that's how we're going to score it. Some other additional coding tips. A dash means that there was no information available about this area. And we're doing comprehensive evaluations, looking at that prior function to determine what's reasonable for us to set for goals, even in all other areas of our plan of care. Typically, we should have information on these areas that section GG is looking at. Again, CMS is saying don't use a dash if the area wasn't looked at because of a refusal or it wasn't relevant for that individual. And how they define not applicable may be a little bit different than your definition. So what CMS for section GG says is not applicable. It means that they didn't do it prior to this episode of illness, and they're not going to do it upon the resolution of this episode either. So somebody who's slept in a recliner chair for the past 5 years, that bed mobility stuff really is not applicable, and they have no intention of going back to a bed, then that would be where that would qualify as not applicable. But just because the person maybe slept in a recliner a week before they went into the hospital, but they were sleeping in a bed and hoped to sleep in a bed upon discharge, then that would be applicable. And we do want to score for that information as well. And again, CMS expects the use of a dash to be minimal. So additional tips. So if we have assistive devices, the use of the device does not affect coding unless they need a cue to use that device. So if they forget to go for the walker, they forget to use the grab bar, and you're cueing them to the grab bar, the bed rail, the walker, the whatever, the reachers, that cue in itself means that they're going to at least be either a 5, which is setup, or a 4, which is supervision. Again, if you just hand it to them and that's all, they say, hey, I need my reachers. Okay, you give it to them, then they're a setup, they're a 5. But if they completely forget to use their reachers and you're cueing them, then that would be a 4 for supervision. Okay, but the device itself does not affect the scoring. Hopefully that makes sense. Some additional tips: if they cannot initiate or complete a task, instead of coding it as dependent, you might want to code it as one of those not attempted choices. So maybe it's a refusal, maybe it's an 88 where it's medically not appropriate for them. So for example, most new folks on the day of your eval, you're not going to do a card transfer initially. That might be scored as an 88 due to safety concerns or medical reasons. You can still make a goal for that area, as I said before, but again, those are areas where we might want to choose an 88 versus dependent. If the person can walk 3 feet but not 10 feet, this is where some therapists vary on their interpretation of this, and I've gotten a few different answers from the coding experts. So if they go, for example, 3 feet and they have such pain, so short of breath that that's all they can do, then you might score going 10 feet as 88 because it's medically not even safe to encourage them to try going that 10 feet distance. However, if they go 8 feet and then they just kind of abandon the idea of walking, they say, oh, I'm too tired, and they just sit down, even though they're not so sure that that's really the case, then maybe you would want to code that as dependent for 10 feet. So I'm hoping that distinction makes sense. Again, if it doesn't, certainly give me a contact and we'll talk about it. So not attempted codes. I know I've been talking about them off and on through the course of this webinar. Again, 7 is not refused, 9 is not attempted before, and 9 is not applicable previously and currently, and it's not going to be applicable upon discharge. 10 is for environmental limitations. 88 is when there's a medical reason why you're not attempting something. And your documentation needs to support why you're choosing one of those not attempted codes. It only makes sense. Time frame, as I said before, for the usual performance upon discharge is the last 5 calendar days. So you can look at the GG data that would be in the assistance notes, look at the OTA notes, look at the PTA notes to gather information about self-care and mobility. So you can do a good job of scoring section GG information. So again, we know that some agencies are going to have some different Section GG communication tools built into their EMR systems. That's a great thing. Your agencies may or may not require a goal for all areas, for example. And so we just need to abide by their guidelines because we ultimately want to help our customer look as successful as they reasonably can be. Again, we all have a stake in good outcomes for everybody for a whole bunch of different reasons. If you've got further questions, please don't hesitate to contact Annie Harris. Her number is listed. Mine is listed below there as well. And again, I thank you really for taking such good care of the folks that we serve, and I appreciate your time and attention to today's webinar. Bye-bye.